Alrighty, well, hello again, everybody. As I'm sure you know, I'm Dr. Beal, and but today I'm really excited to introduce you to the executive director of one of the the Brain Balancing Center. Is that right?
Brain Balance of Wexford. Yeah.
The Brain Balance of Wexford, and we're in for a little roller coaster and a fire hydrant of information. But this is executive director and master physical therapist, or physiotherapist, or physical therapist. Physical therapist, Larry Schultz, who's been in your profession for how long now, Larry?
Over 20 years.
Yeah, that's awesome.
But I was a non-traditional student, so at my age, I should have been in there for 50 years, right?
Of course. And we were just talking about spinal surgery a minute ago, and the difference between the way you put it. You said you want the
cabinet maker to operate as opposed to the carpenter.
As opposed to the carpenter, right?
The carpenter can do the work, but he doesn't do quite as fine a work.
Yeah, and so when you've been, and we were talking this a little bit before as well, is like learning curves and things like that clinically. When we're talking techniques and instruments and all the rest, I'm sure you can appreciate this. But first 5 years you're figuring out your practice. After 5, you really figure out your art. Once you're in 10 years, you're pretty solid. If you've got 20 under your belt, I'm sure you're the cabinet maker. So I'm excited to chat with you. Please introduce everybody, just your background a little bit in a nutshell. You know what I mean? Where'd you go to school? And from there to the Brain Balance Center in Wexford.
Taking a pretty circuitous route, to be honest with you. It's
Yeah.
almost like the 7-year itch.
Yeah.
I graduated originally from St. Vincent College with a degree in history and a minor in philosophy.
Oh my, how about that?
Yes.
Different, I wouldn't think clinical biology, clinical practice, all the rest. But I like it. I like history and philosophy. It's great.
Eventually migrated to the University of Pittsburgh and got a master's in business. Started a computer company when the box was still important.
Oh, that's right, yeah.
And,
sure.
And then gradually migrated to consulting. So I started consulting for medical offices.
Business consulting, right?
Business
Yeah,
consulting,
yeah.
With some computer orientation.
Makes sense.
Then I started getting into rehab consulting. So I sort of migrated to rehab consulting and started consulting for rehab clinics, setting up course, doing sort of business analysis and financial analysis for businesses, and then got an itch, a clinical itch. Strange story, but I won't go into that. But a clinical itch to become a physical therapist.
Yeah.
And didn't really know much about physical therapy other than the fact that I managed them.
Yeah.
Then I went and decided to get a degree and found out I needed 36 credits of science as a prerequisite, and I had 0. So I took 36 credits of science in 1 year. And it was crazy. And then I got into I luckily got into physical therapy school because I didn't realize it was a difficult process.
And where did you go to school?
And I went to Slippery Rock.
Or Slippery Rock. Got it. Gotcha. Great.
And
you and not to get into it like you mentioned, but it was you had like a personal. You knew somebody, right? It intrigued you, not just the business of it all, but there were some recoveries and folks that you know and things like that, right? That's pretty neat.
Yes.
And did it have to do with the brain function, or was it standard musculoskeletal?
No, my nephew was, whether it was formally or informally diagnosed with ADHD, and maybe they said maybe he had a tendency toward Asperger's. And
Gotcha.
So as I'm talking to my clinical colleagues and friends about that, the medication seems to be the standard operating procedure. If it's really bad, there's medication does really good job, and you want to go that route. And I didn't know much about anything, so that seemed to be the direction that we took. And when my son took my grandson it was really my grandson, I think I said nephew, but when my grandson to the doctor and they prescribed medication, and then a year he had to repeat kindergarten, and a year later, when he hit first grade, he was taking Pepsi for acid reflux.
Yeah.
Because he was double dosing on the medication.
Yep.
And that was an eye opener for me, and I realized this is not a solution. This was
when you were still in consulting, right?
I was stopped actually doing physical therapy.
You were doing physical therapy at that point?
Yeah.
Gotcha. And so you could already...
So I was really at the end of the line on that. I was actually working in an environment, didn't really think of seeing a long future ahead of me because I was getting close to retirement age. And so anyway, I was looking for solutions and stumbled across this concept when I was searching the web. And it seemed interesting to me, but it also seemed, as a clinician, it seemed a little too good to be true. And when I see things that are too good to be true, I tend to think they're
So
too
at the
good to be
time
true.
when you found this approach that we'll get into, you were in standard clinical practice,
Right.
seeing
Patients.
just patients, recovering athletes, surgery, post-surgery.
I'd moved
just
past
standard.
orthopedics at that point. I really went the gamut from neuro rehab, orthopedics. I've done skilled home care, and then sort of finished out in skilled nursing, which,
Gotcha.
perfectly honest, is not my cup of tea.
Oh, really? Yeah, yeah. And so now you have this test subject who's needing help with their struggling in school, and you're noticing the ill effects of over medication and things like that. And so, explain what this now. Brain Balance Center is a model to apply the science, right? But what is the science behind it? Where does that come from? What are the underpinnings of this kind of functional brain work? How would you classify it?
Dr. Robert Melillo, who was a functional chiropractor in the Long Island area, began to realize when he started asking questions about his son and nephew, who were diagnosed in the early 90s with ADHD, and that was relatively new. Didn't quite understand what was going on, but he asked the doctor who made the diagnosis, well, how did you come up with that diagnosis? And the checklist process that we use.
Yeah.
And he said, well, this is what it is. And he says, well, that's interesting. He says, and I understand how you got that point, but why did that happen? Like, how did that happen? What causes that?
Yeah.
And the doctor said, I don't know. It's just,
God bless the chiropractors. They always ask that. Yeah, what's the
Totally.
doctors of cause? That's what one of my instructors said, DC, doctor of cause. But I forgot, you told me that before, that it was a chiropractor on Long Island. So just started digging there.
Yes, and so there was no research on ADHD because it was still relatively new. Doctors before that would say, well, you're just hyperactive. That was the term that they used.
Yeah.
Okay, and there wasn't a whole lot of research, except there were bits and pieces of research, in various areas depending upon how hard and how diligent you were in your investigation. So he hit on this split brain research in California that was there in the 70s, working on cutting the corpus callosum to try to control undifferentiated seizure activity. And it had marginal success in that area, but what it did open up was the idea that the left and the right hemisphere of the brain are totally different functional aspects. In other words, they operate on a totally different storyline.
This was one of the first times that had been appreciated?
Yeah.
Was the differences there?
Well, but people have talked about the lateralization theory for a while, and then it tends to get dismissed sometimes. But when you see people that are functioning as a left brain individual or a right brain individual, and the skill set, the functional skill set, is totally different, then you realize that what we live with and what we expect in part of our development is that at some point in time there's an integration of those hemispheres where I have my didactic, intellectual, fine detail, drive, power, motivation, and whatever down the left brain, that matches that intuitive spatial awareness, my ability to extrapolate, to intuit, to sort of get a feel for life. I see the big picture. I'm aware of everything that's going on, and then my left brain puts things into gear, and I start to build patterns and things like that.
Gotcha.
So when I work effectively like that, then I'm integrated and I'm functional based upon my epigenetic markers and my DNA.
Sure. Yeah.
If that doesn't happen, then I start seeing things that are like off.
Yeah.
And immediately I want to try to put a rational explanation to irrational events. And that doesn't necessarily go very well.
If we go down the allopathic road, we just label it and try and treat it like it's a thing. You know what
Absolutely.
I mean? There was a pioneer in the chiropractic world called Fred Barge, and I remember watching a presentation he gave at Palmer College, and he was riling up the students, and he said, come on, and he said, the naming of disease is the worst thing we've done, and he kind of went into it, and he laid into it about diagnosis fundamentally, philosophically, is flawed in a sense, because you give it a persona, an identity to attack or to treat, when really we have no idea why it rose to the surface in the first place, Now, granted, I could see where it has applications, obviously, but, so this is really interesting. So we're looking at the signs and symptoms of a lack of integration, and then looking to rehabilitate whichever side is not showing through, essentially?
It's a connectivity issue.
Yeah.
So when you look at synaptic interaction, if you look at something like that, you see it's sort of an explosion.
Oh,
so
amazing.
those things that fire, they begin to fire randomly early on, but eventually what starts to fire consistently begins to wire, and then you get to that point where it becomes a pattern, and you depend on that, and it helps you function.
Yeah.
But what happens then is through a variety of mechanisms. Some are non-integrated reflexes. I mean, we could talk about a lot of the unique pieces of this for hours.
Sure. Yeah.
But there's a series of perfect storm events that occur in children that cause a lack of development on the right side. Autism, for example, is a classic right brain weakness. Okay,
sure.
The sensory systems are off. The hearing, the cooing that you say to your child is like a jackhammer. The lights are like a strobe. The onesie or the soft blanket is like sandpaper. So that sensory system is off. Their nonverbal communication is non-existent, and so they tend to live in a world where they either develop savant-like characteristics and function in a very narrow perspective, or they shut down totally, almost like they're in a tunnel, and they just can't stand anything. And that's an extreme case. But we see those kinds of things begin to surface as children hit school age, because for the most part, in those early years, we're simply observing.
Yeah.
Do they sit? Do they crawl? Do they
We're not
cruise?
asking them to integrate as
Do
much
they
or communicate.
Yeah, so we just
yeah.
observe, and as long as those milestones sort of fit into normative boxes, then we're okay.
Yeah.
But that development process continues in more subtle ways as they begin to grow, and then we see that emergence of the intellect that occurs between 2 and 3. As that left hemisphere begins to activate, and suddenly, if they are really strong left brain kids with a lot of connectivity in that part of the brain, you start to see some precociousness. Oh, my child's really smart. They really do letters and numbers early. They build a vocabulary. They want to be the leader of the pack. But that's sort of that precept of the terrible twos. It's like suddenly it's my world. I'm going to do what I want to do, when I want to do it, and how I want to do it. Type of thinking. And so you're sort of holding on a little bit, trying to control that left brain while they're going through that process of development. But all those other pieces of development, like how my eyes function, how my ears process language, how my vestibular system begins to orient me to vertical and to rotation and to angular velocity and all those things. How do my fine motor skills and my rhythm and timing, my balance, my synchronization, if you will, of the brain, my coordination, those types of things that we just sort of assume are genetically oriented. Oh, they're just more coordinated than other people.
Yeah.
Well, you may be a higher level of coordination, but that doesn't mean that uncoordinated is a norm. That's a problem.
Yeah, it's interesting.
But we sort of live in that world. Well, it's like just is a terrible word, by the way.
Yeah, right. So it seems like I think in the clinical world, if someone has just a general knowledge, we can probably start to spot those things as clinicians. We were talking about this a little bit, how there are blind spots. As parents, what you just said probably plays out most of the time. As clinicians, we could probably see those things if kids aren't just behaving the way they should, physically, emotionally, just the brain. I remember when I first got out, you look chiropractically, we look at the brain as this big mysterious thing, we just need to open up the channels, get it working right. But then you start looking at the brain more practically, and it just, it's this processing organ, and just, like what's a concussion? Well, it's the brain struggling. You can identify, why do you have blurred vision? Why do you have ringing in the ears? Why do you have memory recall issues? Your brain's hurting. It's a brain bruise. It's a struggling brain. So we start to be able to identify those kind of things. I'm curious, clinically for you guys, I know there's a myriad of a lot of the reflex tests. I remember we talked before about this, like some of the things that you physically test on them. So there's the observations of how they're getting about. But I'm curious, what are there tests that a general physical therapist or chiropractor or dentist or someone could do or ask a child to perform to kind of clue into just if they're not connecting the dots? Like a cerebellar one, we'd tell them do this real quick and we'd see how they do. Is there something like that you guys do on an intake that's a flag that says, oh yeah, this person's going to have XYZ protocol because that test threw up a flag? There's something that like someone like myself or someone in a clinical setting could do. Are there any of those kind of like
If you just had somebody
tests?
stand on one leg,
This is a cerebellar balance kind of test.
just like, do they have the internal proprioceptors to be able to center themselves over that leg?
Eyes closed, right?
Yeah. Well, that would be even more difficult. But sometimes
Even
you see
eyes with
kids,
eyes open.
even eyes open on a flat surface, they can't do it.
Yep.
Or you have them do something as simple as marching. You know, like doing it, and you'd say our kids jump out at you because they can't do it. Like they start doing the same side, they're out of rhythm. Oh, they're out of rhythm. So we assume that should be a fairly easy thing to do, or to
With
do a
eyes
jump,
open, just march in place.
Right. Yeah.
Wow.
Or jumping jacks. I mean, things that we take for granted that
Just
are normal
bilateral, either counter movement or symmetry. Because there's a technique organization in the upper cervical world that one of their intake procedures is to march in place with the eyes closed. And they'll find like people, they march around the room, you know, because their cerebellar proprioceptive system is so off. But I've never heard of a child just stamping one foot instead of doing both.
Well, if you're in our environment,
I gotta come observe sometime.
Yeah, and it's a
that's amazing.
It's profound.
Yeah.
In other words, like the things that we just take for granted.
Yeah.
This is part of this developmental process that we talk about that we just assume that is functioning, because if it isn't, then I think that there's a major problem that's going to give me a red flag that alerts me that there's a problem.
Yeah.
But parents are like, explain this. If you think about the environment that we live in, when I was a young man your age, 1 in 10,000 kids were diagnosed with autism. Last year, it was 1 in 45.
Wow,
okay,
really
so in that time frame,
That's
it's either like, we've done a much better job of diagnosing, which is maybe 25% of the story.
Yeah.
But there's something changing culturally that's impacting that. The things that we know about ADHD, you've seen a doubling of statistics between 2000 and the current year in terms of percentages of kids that are diagnosed with ADHD.
So you think the diagnosis is 25% of the account of the upswing. What do you think is the other 75%? Just out of curiosity.
Well, we are overstimulating our kids with technology. So screen activity definitely shuts down brain connectivity. It isolates it in the oculomotor center. Okay, it's a great anxiety reducer.
So we're not
moving.
Challenging. We're not physical. Yeah.
So movement is the primary stimulation for the brain.
Amen.
So if you think about in the beginning, what's really going on in that first year of life?
Fighting gravity.
100%. 100%.
We talk the same language with that.
100%. And so that brain, all that connectivity is primarily done to control gravity. Because we live in a world where we don't think about gravity. But it's significant enough that astronauts that come back to Earth after being in the space station for months are in a wheelchair for 2 or 3 months after.
Wow.
So that baseline, what I call the idling speed of the brain, that baseline activity that allows us to process gravity seamlessly hasn't been activated until it does, and then I return to function again.
It's really interesting.
So if I'm missing that piece for some reason in that first year to two of my life, then what happens, instead of starting to open up reciprocally, so using reciprocal innervation, which is a brain function, to begin to move my body appropriately, I begin to open up and unwind, if you will, and I become hypermobile because there's no activation there.
Yeah,
so
that's crazy.
You see a lot of my children that not only do they have weak core, like they can't do a push-up, can't do a pull-up, can't do sit-ups, they can't do basic things that would allow them to move their body against gravity. They also tend to have a profile that their joints are hypermobile. It's not just like hypermobility in one specific joint.
It never even challenged them. Yeah.
So they have collapsed arches.
Yep.
They have hyperextension of their knees and their elbows and their wrists. And I don't do the spinal thing, but I would suspect that they're hypermobile in the spine as well.
Yeah. And what was I going to say to that? There was an observation that I was going to have. I was thinking about so many things, thinking about my personal life, thinking about like with my own kids and things like that. That's what I was going to say. We've always looked at it structurally, where kids are put in those little gumdrop seats, you know what I mean, or in the plays, and there's no opportunity for them to actually pick their head up or develop that lordotic curve on all fours and figure that out, just structural basics, but they parents plop them in those seats because it's convenient and it's cute, but it's like, what is that doing to their spine? You know what I mean? If you fast track that whole developmental phase structurally for the lordotic curves to come into the neck and the lower back, you know.
Monitored tummy time has been the biggest disservice to our childhood population over the last 2 generations.
You say that again? You said
monitored tummy time.
Monitored tummy time.
So what this thing is to prevent, to protect against SIDS.
Gotcha.
That's like but you can't let them sleep on their stomach. You got to be careful and things like that.
Yeah,
so now we promote car seats where basically you're putting infants in situations where they're on their back in 45-degree angles, visually stimulated without necessarily having the gravity-based gross motor skills that are beginning to learn how to build that foundation. And so you end up getting overwhelmed. So you see a lot of children that have non-integrated Moreau. Okay, so they tend to be they tend to have a higher percentage of fight or flight response. So instead of being really having that sympathetic discharge as a result of real fear and real danger, they tend to perceive danger in ways that set them into that primal part of the brain where they begin to overreact.
So if you can, for me, go back and connect. We were talking about how if we're not putting them on tummy to pick up their head and look around at the world around them, and instead we're at the 45 visually but not physically, how does that connect to an overactive sympathetic response?
We have these 8 basic primitive reflexes. Those are just 8 standards.
Yeah.
All right.
So
they range from Moreau, rooting, Palmer, spinal gallant, the ATNR, which is that defensor position, the tonic labyrinth reflex, which where the head goes back behind the spine. They open up and then they flex when the head's forward. Then you have this crawling reflex and the Landau, which is when you hold the kid up by their stomach in the air and they go into their body, their upper and lower body move together, right? So those things are essential for normal functional or normal
foundation,
like the brain, that's normal neurological function along with the other reflexes. But those reflexes, we've always learned, at least in school as a clinician, that they are necessary to be there, but that they naturally just sort of integrate on their own within a year to 18, maybe 2 months, 2 years, depending upon, sometimes the TLR takes a little bit longer. But that's a gross assumption. Like, nobody's testing that.
Yeah,
like, I would think that every pediatrician, for example, should be doing cranial nerve assessment and reflex integration protocols every visit. It's just standard operating procedure.
But it's just done earlier on, and then.
But we do it one time, and it's just there, and then we've all learned that they just go away.
Yeah.
But if I have a non-diagnosed or unintegrated reflex, it manifests itself in a variety of ways, and it short circuits development. So now I have a brain that's actively trying to establish sensory integration, and I have a reflex that's getting in the way of that, and so it's conflicting pathways.
And that I want to point on, because I missed that the first time we talked, and the observation was that the reflex, as the brain integrates, that reflex should go away because it's not a natural, you know what I mean? Your brain no longer needs it, so to speak. And so the presence of the reflex maintained over time is the pathological indicator. You know what I mean? I think that's a very interesting distinction initially for practitioners. So most of these should integrate in by what age?
Well, you would think that most of them integrate by a year for sure. Like Moreau should be gone by 6 months. But again, because it's such an inexact science, sometimes it may take longer. But the idea is that you should be able.
You're finding them in some
almost 100%.
Really?
But it's like, in fact, if I took a room of 100, in fact, Dr. Malolo was when I was talking to him about it.
Up to what age, by the way?
In adults. We see in adults. Totally.
So give me an example of one in an adult.
Let's say that I'm standing. Let's say I'm standing in with my arms down to my side, and somebody takes my head and passively tilts it up. Okay, if I tend to feel like I'm falling backward, my toes come up, and I feel like I'm kind of falling backward a little bit. That's a TLR, a lack of TLR. If in fact I tilt my head forward, and I sort of feel like I'm rocking onto my toes, that's a flexion TLR that's activated. And sometimes you see children that begin to be toe walkers early on because that reflex dominates. And so as a therapist, trying to fix toe walkers.
You know what I'm interested in? You know the, sorry to interrupt, but my brain, what was that thing? it's that pressure plate game, the Nintendo Wii Fit,
Yeah,
the Wii Fit board, and it checks your pressure points front and back. That'd be a fun field day. Set someone on that, 'cause you can see it real time, and have them do that and see where it falls. Because I've thought about that too, just getting one of those for Sarah, but just closing your eyes and seeing how your center of gravity sway is. But I've never thought to extend and flex and see what that does.
Right. With the eyes closed, by the way.
Yeah.
So what's interesting is that if you think about these reflexes, which again is a subject for a whole conversation, those are really training wheels for functional development.
That's amazing.
So, like for example, when I get the crawling reflex, if we go back to the beginning, I have to have enough core stability to be able to get up on all fours. And what you see is kids splaying their legs out behind them when they try to get their knees underneath them, because it requires a certain core stability to be able to withstand that force in all fours. But then when I start to move, I suddenly I realize intuitively that left-right reciprocal crawling is what keeps me stable. If I can't do that, then I start crawling on my side, crawling on my back, and it's like it doesn't much matter because the whole goal is to get to walking anyhow. So we dismiss that as an essential piece of growth and development. So that crawling reflex, for example, in isolation, not only allows the child to crawl, but it activates the convergence-divergence mechanisms in the eyes. So if you think about the training wheels of all of these things that we normally take for granted are being built, if you will, to a point where when they go away, the brain now has a head start to be able to activate those and complete the process as I begin to start walking and I start to develop a more sophisticated vestibular system. If those reflexes don't integrate, now I've got a problem. I will never complete the sensory integration actively.
And I know we don't have as much time to go into it, but using that as the example, some of the therapies that you may deploy, maybe then taking them back to that and having them crawl, I would guess, right?
Yes.
To integrate that in, to rebuild that in.
In severe cases, that's the case, but for us, it's simply like there's a series of movement patterns which replicate the reflex pattern, and in the process of building core development, because they're intertwined. In other words, you can't integrate the reflex if the core mechanisms that we process against gravity, if those aren't effective, then it tends to get stalled out a little bit. You see some movement toward integration, but you don't see a complete integration without core developing.
And just out of curiosity, you guys are doing a little bit of both at your center probably. You're probably doing some traditional therapy to work on the actual muscles that might
Although
need
we
to
don't
be,
call it therapy because it's really more functional training.
Got it, sure. But the physical function and then the brain as well. 'Cause that's what when I try and explain to patients, I say there's this functional neurology when I'm referring to basically what you do and what our profession does in functional neurology is very similar, I'm sure. And that's what I tell them. I say it's basically PT for your brain. It's like where are the lobes that we need to work on? How can we grow them? How can we stimulate them? But what's as a actual physical therapy center, you can then also probably help to facilitate the muscle work that's going to need to be accounted for. Because if they didn't even develop, they'll be, I'm sure, spastic on one side and weak, low tonic on the other side that you guys probably have to integrate into your work. What you call it, the functional training into the brain training as well.
And it comes down to the fact that if you assume that a child displays asymmetry in connectivity in the hemispheres, so if everything's working, then we don't see them because life is proceeding normally.
Sure.
So we see the people who are either they struggle with learning in a sequential way, so that would be that percentage of the population, about 15%, that is traditionally learning disabled, whatever you want to call it. And then the one that is increasing exponentially is that right hemisphere under connectivity, which produces the spectrum children, ADHD, OCD, ODD.
I'm curious.
Tics, Tourette's, all those kind of things.
Where do you get are there situations, and what would you see to see the opposite, where the right brain is the dominant? Does that ever happen where the right brain is more dominant than the left?
In fact, it's actually the norm, believe it or not, even though we tend to see more of the right hemispheric weakness.
It's probably easier to peg those.
Yeah, because what is the typical response for a left brain weak person? They're going to be tutored.
They're going to be, okay, gotcha. They're not driving as much, they're not over-dominant.
The motivation's there, self-esteem is lacking, They struggle with routine. They aren't puzzle oriented. In other words, they're not the ones who love puzzles early on.
No.
They don't like Legos and things like that.
So it just looks like apathy, or just looks like
they're athletic. They're coordinated. They tend to be, that right brain is more developed. So they tend to be like, that's probably where the idea of dumb jock came from. Like,
oh, wow.
So you have
Got
the
it
athletic
now. Okay.
social person who just doesn't learn. So when you get to pro sports, for example, the reason that some super athletes don't make it is because they can't follow the plays. So when you get into high level where they have high strategies and they have to know where everything is and they have to understand what everybody else is doing type of thing, they play intuitively, which works on the streets or like whatever, but they don't follow the plays.
Yeah. That is a brilliant observation. That's really fascinating. Yeah, because when at the high level, it does require both.
Can you imagine, for example, if in fact we were able to take a subset of a population, so let's say we were breaking our assessments based upon demographics, and suddenly you have a particular population that has always been underachieving, and we just say, well, they're just low intelligence type of thing. But what if they are epigenetically marked as left brain weak, for example, and you were able to change that so that the learning mechanism that we measure in schools was able to be restarted, if you will. Suddenly, you change the conversation totally.
And you've gone into we're just about out of time, and I'm going, oh gosh, if we open up that epigenetics box, I'm going to a conference next week where we have someone talking about epigenetics and what kind of changes can we see and make and research and all the fun stuff. But we do have to wrap this up. The other thing that I was thinking about is I so want to get into what you're actually doing in there, but it's actually beyond the point of the conversation. The point of these conversations is just to learn the indicators, be able to appreciate it, and you do whatever the heck you do. I think it is interesting that you use a couple terms, and obviously if a lot of this clinical application started from a chiropractor in Long Island, there's so many probably crossovers within our profession in terms of this, because you use terms that I've heard before from the stage. There's a diplomate in pediatrics in our world that used that term perfect storm, and he did a lot of that kind of stuff. We talk about integration from a proprioceptive model a lot of times in chiropractic, but I think it's just so cool just looking at those reflexes and looking at the bigger picture, because fundamentally, I mean, when you talk about gravity, I'm going, oh my gosh, you're speaking to our heart in upper cervical, because there's one of my friends, he talks about, that's how he educates. We talked about education earlier when Larry first came in. He always talks about to his patients about gravity as the first stressor. And your idle thing, the conversation about idle, I'm going to have to chew on that for a while. I love that. What did you call it? The resting idle state of the brain?
The idling speed. I call it the idling speed of the brain.
I love that. The idling speed of the brain. There's so many cool overlaying observations and communications in our fields that I think I just love that. I'm going to be chewing on it for a while, but we're out of time.
But as clinicians, the takeaway is that what we should be worried about, besides our individual patients, which are always primary and important for us, is the fact that culturally we are in a crisis mode and we aren't even aware of it. We are talking about the wrong things, but Rome is burning, if you will. So 25% to 30% of our childhood population fits into one of the profiles that we're talking about.
That's
and
crazy,
the
right?
projection is, and this isn't a brain balance story, but the projection by people observing these tendencies is that in another 20 to 30 years, we might be talking about 40 to 50% of our childhood population that is struggling. And the question is, why are they struggling? So we have diagnostics that would say, oh, this is what's going on, this is what's going on, but that doesn't solve the problem. It treats the symptoms. It treats the symptoms, or tries to treat the symptoms, but it doesn't. Why is it popping up?
Yeah. Exactly. Any thoughts on that? And you mentioned the screen time.
It's screen time, bad food. Okay. So really, it's a holistic concept that we all talk about, which is that there are factors that are driving this story. So because we don't move effectively, and because we're not on our stomach to a certain extent, even though it's not a pure cause and effect, we are creating a storyline that inhibits our brain from functioning the way it was meant to function. Okay. Amen. And when that happens, and we start feeding our brains with our bodies with bad food choices, which impact the
Poor
enteric
gut
nervous
goes
system,
to
and suddenly we start to
poor
have central nervous system
neurotransmitters.
inflammation,
Yep.
and then we overactivate screen activity, which we know produces aggression, and
Yep.
it distorts the development, and it changes brain connectivity. So you put all these things together and you put them into a big pot, and suddenly you have an increasing number of people who, children, for example, and adults eventually,
Yeah.
who are struggling.
Yeah, in our world, we layer onto that the cesarean industry. Cesarean forceps deliveries and what that does to the spine. You know what I
Right.
mean? They're coming out with blown ligaments. You know what I mean? And it floors me. We can chat about that another time. But thank you. Like we talked about a little bit, there are the idea with clinical conversations is primarily for clinicians a little bit to get a better appreciation for this. So any last words to, it could be local clinicians in the Pittsburgh area, could be international folks. I know a lot of chiropractic students and other folks like that, but just any last words in terms of where they can find you if they wanted to learn more about this, or just any last words for them in general,
You can globally, regardless of where you are, you can Google brain balance centers,
Yep.
brain balance achievement centers, and there'll be facilities around the country that will pop up for you, in that thing. There'll be research papers and things like that you
Yeah.
can, if you're aligned like that. And there's testimonials and there's storylines and things
Sure,
like that
yeah.
that you can get a handle on. The hardest part is to get outside of the traditional, the conventional wisdom thinking, which is that there are a lot of different ways that we have overlooked along the path of our clinical story. And the problem is that we want to make sure that we are process driven and that we are looking at an individual uniquely and like, what can I do to help that child?
Yeah.
Okay. And I may not have the answer, but I'm looking for somebody that does have an answer because we are all in it together. Because if those statistics that I talk about impact us, which they will, that it's to our benefit to find solutions.
Yeah, big picture. Love it. Thank you,
you.
Larry. It's always a pleasure. I told you it would be a little bit of a fire hose. So thank you guys for hanging out with us today. If you have any questions at all, you have any specific practitioners or people you want me to chat with, we'd love to hear about them. Let me know. Otherwise, questions you can ask associated with this video. I'm sure I can forward them on to Larry. You can probably comment on it once I show you where the videos are posted and all the rest. So please feel free to ask questions. And other than that, we'll see you guys next time. Bye now.
Thank you.
All right.